Hello, my name is Kevin Wilk, and today I'm going to discuss return to play criteria for the overhead athlete. It's a pleasure to present this information to you. I'm sorry I'm not able to attend the meeting in Switzerland and see my good friend Mario Bazzini and all my friends at the Swiss Sports Physical Therapy Group. But due to unforeseen circumstances, I have to stay home. I'm sorry I'm missing the trip to Switzerland, the beautiful country, as well as the great city of Bern, Switzerland. But I'm sure this conference is going to be a tremendous conference, as it has in the past. I bid you greetings from the United States in Birmingham, Alabama, and Champion Sports Medicine. This is Birmingham, and this is the St. Vincent's Hospital complex in our building where we perform physical and occupational therapy, as well as orthopedics and sports medicine. As I mentioned, today's presentation, I'm going to discuss injury rates, but also why a return to play criteria is so important for the overhead athlete, and in particular, the overhead athlete who's a throwing athlete. We're going to talk about particulars, in specifics, objective criteria to initiate a throwing program, as well as a return to play criteria as well. 61% of all the baseball injuries sustained to a baseball player on a team occur to the pitcher, of which the injuries to the pitcher, 72% occur to the shoulder and the elbow. Therefore, a high rate of injuries occur to the pitcher's shoulder and elbow, and therefore an objective criteria is necessary to ensure a re-injury does not occur. Why do injuries occur? Well, there's a lot of theories and a lot of data out there. The work at American Sports Medicine Institute here in Birmingham has shown that pitching when fatigued and pitching too much are the #1 risk factors for young people. At higher levels, risk factors include throwing at max velocity and altered mechanics. When you look at the throwing motion, it's obviously a very complex, it's a very high stress motion occurring at tremendous angular velocities. It's the fastest human movement. Work by Dr. Fleisig here at ASMI has shown that the shoulder moves in the elite pitcher over 7,000 degrees per second. And at ball release, from late cocking the ball release, this rate occurs at 0.03 seconds. When the arm is all the way back in this late cocking position to throw a ball, it's half body weight trying to dislocate the shoulder out the front. And in the deceleration phase and follow through, it's about 1 times body weight trying to separate your shoulder from your body. So as you can see, there's tremendous forces. Even at the collegiate level, 75% of all the injuries that occur to the shoulder and or elbow. Some Major League Baseball injury data has shown from 98 to 07, it was a 2-to-1 rate for days on the disabled list for Major League Baseball players shoulder to elbow. So for every 2 days on shoulder, it was 1 day for elbow DL days. From 07 to present, that has flip-flopped. It's 1.8 days to 1 elbow to shoulder days. As I mentioned before, youth baseball players get hurt for different reasons than the elite professional baseball player. Many times the youth baseball players have altered mechanics, and they almost throw like they're throwing a pie or a sheet of paper where they push it and lead with their elbow. They also have weakness in the core of the body and legs and tend to throw with more arm than anything else. The elite thrower that exhibits tremendous or normal biomechanics is throwing with their entire body, and over 60% of the energy is generated from the legs and the core. In the United States of America, 17 million kids play baseball. And studies again here at ASMI by Dr. Fleisig and his team have shown in age groups 9 to 14, over 50% of these individuals will complain of shoulder and or elbow pain during a competitive baseball season. So are these injuries an epidemic, or is it just an occurrence that we just have to come to grips with? When we look at the biomechanics of throwing, here in slow motion, using motion analysis, you can see there's tremendous forces that are generated from the lower extremity, from the legs as well as the trunk. And look at the amount of external rotation that occurs in this late cocking phase. And then at ball release, there's a slight internal rotation, pronation, but also tremendous forces generated through the scapula in the core of the body. We know with our rehab program we go through phases. Phase 1, we're trying to normalize motion, activate certain muscles, reestablish muscle ratios, good scapular base. Phase 2, we progress the strengthening program to include more core, legs into the equation, and also continuing a stretching program. Phase 3, we progress to what we call our advanced throwers 10, where there's sustained holds, plyometrics, and the person continues to do a stretching program. And then lastly, the return to activity phase, they're still doing their strengthening exercises, their stretches, their plyometrics, but now we have to establish a criteria, if you will, to see if that thrower can go back to the sport without sustaining a second injury or making another body part susceptible for injury. So obviously, objective criteria and establishing a database is very important. So what are things that we look for in the overhead thrower to see if they're ready? Well, maybe first, and I don't want to say foremost, but an important criteria is their range of motion, that they have adequate, non-painful range of motion that's specific for their sport. So a thrower, we would expect more range of motion of a shoulder than tennis players. Second is strength values. And we establish these strength values through objective testing, either with Isokinetics or a handheld dynamometer. In addition to strength criteria, we look at stability, shoulder stability, and we do stability testing as well as provocative tests to see whether or not the person has irritability of their rotator cuff and or shoulder complex. We want them to demonstrate proper throwing mechanics, and we can do so by filming or using some type of device in the lab or also in our physical therapy clinic to see if they're exhibiting good throwing mechanics. And they've also completed a successful rehab program, which includes proper strengthening, range of motion exercises, but also plyometrics. And then lastly is a functional scoring system, which I'll review with you in a moment. So range of motion is important, and most overhead throwers have range of motion like you see here, excessive external rotation, and a limitation, if you will, or an adaptation into internal rotation. The best way of measuring this external and internal rotation is with stabilization to the scapula. So what we do here is we grab the person's elbow, the arm is in the plane of the scapula, they're up at 90 degrees of abduction, my thumb is on the coracoid process, my fingers are on the body of the scapula posteriorly, and I rotate the arm until the scapula starts to tilt. And I'll do this into internal rotation, and I'll also do this into external rotation. This has been shown through several studies we perform, one published in the Journal of Sports Health, to have the best reproducibility or reliability for internal and external rotation measurements. And as I mentioned before, these adaptations are necessary and critical for the overhead athlete, especially the thrower or tennis player or volleyball player, to perform their activity successfully with proper biomechanics, but also without a higher risk of injury. We believe if somebody goes back to overhead sports with a decrease in external rotation from the norm, that would make that person more susceptible for injury. The same thing with a significant loss of internal rotation. So when we measure this, we want to be as objective as possible. We use a goniometer that has a bubble on it to ensure that the stationary arm is vertical during these range of motion measurements. We can also use a digital inclinometer as well. We also introduced back in 2002 the concept of total motion. So when we add external rotation and internal rotation together, we get a total rotational arc of motion. We've studied this in this month's issue of American Journal of Sports Medicine. We've shown that if your total motion is outside this 5-degree window, that makes the baseball pitcher more susceptible for injury. So we're more concerned about the total arc of motion than the loss of internal rotation as well. In that article in this month's issue of American Journal of Sports Medicine, we documented that the #1 risk factor for professional baseball pitchers was a loss of external rotation. So if they didn't have sufficient external rotation, that shoulder was at a high risk. In addition, the second most common risk factor was the alteration in total rotational motion. What is preferred as far as range of motion? Well, we've looked at this for the last 9 years. Our N is about 826 professional baseball pitchers, and we'd like to see around 131 degrees of external rotation at 90 degrees of abduction. Internal rotation should be around 53 degrees, giving a total rotational arc of motion 184 degrees of motion. And we think that arc of motion is very, very important. We've published this as well in Clinical Orthopedics and Related Research in 2012. Other motions we look at is passive shoulder flexion. This is very important. From this standpoint, we look at shoulder flexion, and a paper we published last year showed if you lost shoulder flexion, it puts your arm at a greater risk of sustaining an elbow injury in the professional baseball pitcher. We also look at cross-body motion, so the ability to bring your arm across the body to see how much horizontal adduction you have. So we measure that, and as I mentioned before, we do have a database on that for professional baseball pitchers. The cross-body motion should be around 42, 43 degrees of motion, with 0 being vertical. During this cross-body motion, we'll also see the pitchers have external rotation. So this is the throwing side, non-throwing side. When we horizontally adduct the arm naturally goes into external rotation. And we believe that's due to retroversion or retrotorsion of the humeral head. Same as in this professional tennis player. We also look at laxity before the person starts the throwing program, regardless of their pathology, and we'll measure anterior displacement, posterior displacement. And we'll do that with a drawer test, but also with a fulcrum test. I'll also measure it posteriorly as well. And when I do my posterior drawer test, I actually bring the arm up higher, and when I translate, I'm translating in about a 30 to 35 degree lateral position. So when I grab the humeral head, I am not going completely vertical, rather I'm going in an oblique, posterior lateral direction. This ensures that I clear the posterior rim of the glenoid. If I were to go straight posterior, I would hit the rim of the glenoid, and that would give a hard endpoint. I also like to do a clunk test or a circumduction type of test to see whether or not the posterior cuff is irritated. So I'll stabilize the scapula, I'll compress the humeral head, and I circumduct the arm as well as horizontally abduct the arm to try to see if there's any encroachment, any impingement of the cuff on the posterior superior rim of the glenoid. Very important to do. If there is irritability, many times they'll notice this with throwing motions. We do isokinetic testing as well. We think that's very important to objectively measure the baseball players or overhead athletes' objective strength. The range of motion or strength test that we look at is internal and external rotation at 90 degrees of abduction. In addition, we look at shoulder abduction and adduction. We have published these values on a large series of professional baseball pitchers, and we'd like to see the external to internal ratio to be around 70 to 72%. Our goal is up to 76%, but that rarely occurs. In addition, we look at external rotation to abduction torque values. And that ratio, that unilateral ratio, should be around 68 to 73%. In addition, we look at peak torque to body weight ratios. Your external rotator should be between 18 and 23 degrees, whereas your internal rotator should be between 26 and 32%. Your internal rotators are very important accelerators that creates arm velocity. And then lastly, bilateral comparisons. We've shown that the throwers, the pitcher's shoulder, will be slightly weaker on their throwing side going into external rotation and much stronger by about 15 to 20% going into internal rotation. We also like to measure shoulder strength regarding the scapula. We have not published those values, but we do have ratios for the scapular muscles in the throwers, both bilateral comparison, but also unilateral muscle ratios. So we have established some numbers related to scapular strength values and ratios. And I know Ann Koels from Belgium, who is at this Congress, has done some extensive work in this area and some excellent work looking at the scapula as it relates to shoulder pain. And we watch what she does with great interest, and I greatly appreciate and congratulate her on some tremendous work. So in the pitchers, we've found on their throwing side, their scapular elevators are 4 times stronger than their scapular depressors. In the throwers, their retractors are slightly weaker than their protractors. So their retraction is 88% of their protraction. And this is interesting when we compare that to the non-throwing side. It's almost a 5-to-1 ratio, scapular elevation versus scapular depression, compared to retraction and protraction, which drops off to 71%. So in the throwing shoulder, we've noticed that the serratus is stronger on their throwing side, and also their scapular depressors are a little bit stronger. This is also true when you compare them to non-throwers. So we had a large group, I think it was about 62, 63 individuals that were non-baseball pitchers, and you can see that their upward or elevators of their scapulas were much stronger than what you see in the baseball pitchers, and they had weaker serratus anteriors. The last criteria is appropriate rehab progression. So we want to make sure that all of our throwers do plyometrics, 2-hand throws as well as 1-hand throws prior to starting a throwing program. We also do some dynamic stabilization exercises, dropping a medicine ball for 30 seconds and doing catches like you see here, as well as throws up against the wall. One of the tests that we're collecting data on now is called the ball drop test. The person lays prone, arm is up at 90 degrees of abduction, and they use a 2-pound ball, and they drop it and catch it. For 30 seconds on their uninjured side, we count the number of catches as well as drops. And then they'll do it on their dominant side. The ratio we're looking for is on your dominant side, in 30 seconds you get at least 90% of the catches that you got on your non-dominant side, and we're pain-free. In addition, our expectations are that you actually get 10% more ball throws and catches on your dominant side. The last test is something new. It's called the Quick Board. It's up on the wall. We use an Apple iPad computer, and the person would touch these yellow lit up balls in 30 seconds, one shoulder compared to the other, and we look at ratios again. We want the throwing shoulder to be about 10% better than the non-throwing shoulder. There is one subjective test score that we use. This was published by the Curl and Jobe Clinic out in Los Angeles, California by Alberta, where it's a series of questions that ask the thrower, how difficult is it for your shoulder to get loose? Have you experienced any shoulder pain? Do you have any weakness? How is your angular velocity? And so forth. And there's equated to a score. There's several papers that have been published on this in the collegiate as well as the professional thrower, that if they score their shoulder high, they actually have a very nice and successful criteria to return to play. So hopefully this presentation has helped you in some way as far as gaining information on the overhead thrower. I really appreciate your attention. And again, my sincere apologies for not being able to attend the meeting in Switzerland and see my good friend Mario Bazzini. I look forward to seeing you in the future, and I wish you a very successful conference. Thank you very much.